So to introduce the panel, and it ought to be in order of appearance, but that's not the order in which it's written on my notes. So forgive me if I bounce back and forth. Morris needs no further introduction. So I'm going to introduce my colleague Lorraine Schwanberg first. And Lorraine works with me. She is the head of incident management in the National Quality and Patient Safety Directorate, and open disclosure falls under that under Lorraine's remit also. So the team that are leading out on the implementation of the Patient Safety Act and the open disclosure framework across the HSE and with our partnership organisations also. Lorraine joins us. She's here about 2 years now and has come from the NHS, has a vast experience in the NHS in the area of incident management, but prior to that she worked for many years as a paediatric and general nurse. Another member of the team heading up open disclosure is Angela Teisel. It's very interesting actually when you read these bios of people that you work with and you realise that they had a life before incident management. So Angela likewise has worked particularly in the area of open disclosure for many years with the development and implementation of our original open disclosure policies in the HSE. But prior to that, Angela had a background in nursing and midwifery and had clinical specialist nurse roles in minor illness and ear care, as well as being a senior sister, a team leader, and work in the NHS as a nurse lead in a walk-in centre. As I said, very interesting to know that people had a life before incident management. Georgina Cruz is the National Manager of the Patient Advocacy Service and has worked with the service since its inception in November 2019. She joined as Acting Service Manager and Advocacy Team Lead. She has over 17 years' experience working in the area of citizens' rights and entitlements across the health and advocacy sector and has over 15 years senior management experience otherwise. Georgina also has frontline experience of direct advocacy provision, having previously worked with the Citizens Information Service for 12 years, and is also a graduate with an advanced diploma in advocacy practice provision, patient safety complaints advocacy, human resources and leadership management. Quite a mouthful, Georgina. Sean Egan joins us from HICWA, and Sean has over 20 years experience in working to improve quality and patient safety in healthcare for patients. Sean is a pharmacist by background and has led in key areas of monitoring with HICWA, including a focus on pre-hospital emergency care and infection prevention and control, amongst others. Caroline Donoghue, and sorry, Bernie, I've skipped over you, but Caroline Donoghue is the NMBI Director of Education, Policy and Standards, having joined the organisation in 2021. Caroline is a registered nurse with over 20 years' experience in multiple nursing roles and a keen advocate for education and continuous professional development, as evidenced by her postgrad qualifications. She told our team leader a story after all of those data points about the years. Her story was that 1 year at the NPSO conference, you presented a poster and won the overall prize for that competition. So you've come full circle, and welcome back. Thank you very much, Caroline. So Bernie O'Reilly, sitting between Sean and Caroline. Bernie is a member of the Patients for Patient Safety Ireland. She's followed the progress of the HSE open disclosure policy over the past 8 years. Bernie is a member of the Open Disclosure Steering Committee, as well as a member of the Patient Safety Act 2023 HSE Implementation Working Group. Bernie works with us continuously in the NPSO, and we're very grateful for her very valuable contribution. Most recently, actually last year, our medication safety webinar for World Patient Safety Day, amongst other activities. in the very hot seat at the end that I occupied this morning, you pulled the short straw there, Catherine, is Professor Catherine McHugh. And Professor McHugh is a consultant endocrinologist and associate academic officer at Sligo University Hospital, a graduate of University of Galway. She has a special interest in endocrinology, eating disorders and medical education. I should have added open disclosure because Sligo, as was alluded to earlier, is an exemplar in the implementation of our own open disclosure policy. Professor McHugh is a Fellow of the Royal College of Physicians of Ireland and is currently on the Council of the RCPI and is chairperson of the MRCP Examination Board, a term that still strikes fear into me all those years on. So that's our panel. So we might open up with a broad general question on the open disclosure journey from your own perspective. So if you would care to start the conversation, or I can go along the line. But Angela, I might start with yourself, seeing as you've been with open disclosure, that journey from the start.
Okay, thanks, Orla. Yeah, it's been a massive journey of learning and development, and I think a lot of progress as well. We're at stage now of 13 completed years since we started work on the project. And I believe that we did have a very comprehensive approach to the development of the HSE open disclosure policy and the implementation of the whole policy and programme across health services. I suppose going back to the beginning, it was a joint initiative between the State Claims Agency and the HSE, which really sent out, I believe, a very important message into the system that, that your employing body and your indemnifier are telling you to engage in this because they expect you to do it and because it's the right thing to do. When I use the word comprehensive approach, I suppose I say that because there's been so many legs to this journey around open disclosure. When Anne Duffy and I, in the early days, were asked to write the policy and implement it, we didn't just sit down and write a policy. So we did a lot of the research in other countries, learning from the best practice there. And there was a particular study that came out in 2011, and I feel everybody should read this study. It was a 100-patient experience study that was done by Ricadema. And it was Australian, and they were looking at open disclosure was implemented there since 2004, but it still wasn't meeting the expectations of patients and families. So that study was very influential for us in how we actually developed and rolled out the policy for the HSE. And then we followed on then with having a pilot for open disclosure, and some of the key areas, for me, around open disclosure has been the whole area about, building relationships. For me, this journey has been a journey about relationships with people on the front line, relationships with people in our professional bodies, our regulatory bodies, with, I must say, our patient groups. We've worked with patient groups from the very beginning, and I really feel that they have steered this programme in the right direction, particularly Patients for Patient Safety Ireland, who've been hugely influential. I think the training and education, we've really developed that training and education programme. And when you look at international best practice around open disclosure, the two things that always come up are training and leadership. And they really were the areas that we focused on. So developing and redeveloping and improving our training programme, over the years, introducing e-learning, the face-to-face skills, and revising that and developing it all the time. The leadership piece as well, we work with really great people across all of our HSE services, national QPS leads down to our QPS local leads, our own trainers, our own open disclosure leads who do phenomenal work, really do, and they do this on top of their full-time day jobs as well. So these people have all made, to me, such a difference in the implementation of this policy and have had a massive role to play. I think just moving on then, just the relationships we've had with a lot of the medical bodies, the National Doctors Training Programme, the Forum of Postgraduate Training Bodies, the trade unions, building those relationships, going out, meeting with people, telling them about the programme and working with them. Because as Maurice was going through the list of all the people just during the presentation, I was thinking, we work with all of these people. There's nothing new in the framework because we work with all these people already, but it's just about bringing that work, I think, a bit more forward. Probably time to be quiet now, or is it? Yeah.
I'm just thinking that was 8 years. It's maybe Bernie, from a patient's perspective, your own reflections on the open disclosure journey.
Well, I suppose my introduction to my open disclosure journey commenced 17 years ago, the day my husband died. Obviously, he couldn't avail of open disclosure because you can't mitigate against the consequences of death, but you can engage with families to make their journey easier. And my first 9 years of my experience of open disclosure, I didn't even know the word open disclosure. My first 9 years of seeking question or having questions, seeking honesty, was pretty poor, really extremely poor. And I just felt I got a very guarded version of half-truths. So I didn't really come into the open disclosure arena knowing what it was about until 9 years after my husband's death, and that was when I joined Patients to Patient Safety Ireland. I had an inkling. Cornelia Stewart had said to me things were changing around being honest with patients and their families, and I thought, well, that would be good. So when I joined Patients to Patient Safety Ireland, I told my story and made a great, Margaret Murphy made a massive impression on me. And I thought, so now I've told my story, what next? And I said, I'll come to another meeting, I'll just see what's in this group for me. Maybe there'll be nothing in it for me. So at the next meeting, I met Angela Teisel, and she introduced me to the whole topic of open disclosure, and she said, we need to hear patient stories, we need the patient voice as part of this to drive the agenda. And I thought, yeah, do you know what, I can actually engage with this process. So that's where I started following the HSE's journey through open disclosure and the processes. Along the way, I started to understand the fear from staff, the sense of people who had done really good work and had been, built careers on patient care and caring for people in a meaningful way. And suddenly one day something happens, an adverse event happens, and that impacts that person so much that they've got this massive sense of fear, abandonment of everything that they've worked towards, their careers potentially coming asunder, and their emotional well-being coming asunder. And I started to see both sides. Up to that, I'd only felt my own pain. So when I started to see both sides, I thought, yeah, do you know what we need? Patients need the honesty, I need the honesty, but we also need that staff can feel safe in that environment. I know people fear litigation, and people are right to fear litigation. We're a very litigious society. But just know that the legal system is quite robust. I followed the legal system for 3 years. When I couldn't get my initial answers from the hospital, I did explore litigation. I needed to get expert witnesses to, basically I had my husband's file. That was all I had. I didn't have a lot to go on. And some of the things I was concerned about weren't even mentioned in my husband's file. So litigation it's people going through the legal system. It's not where patients want to be. It's not where families want to be. They want the honesty without having to go through those processes. So I'm saying, just try and trust the system. Try and work with it and try and trust. And mostly support each other. I've said it before. If you're in an incident, or if somebody you know is in an incident, if one of your colleagues is in an incident, be kind to them, support them, because they're, for the grace of God, go you. And in all of your lives as healthcare professionals, you will eventually have an incident that you're going to have to disclose. You're going to have to meet a family, and families of people who have been harmed or patients who have been harmed themselves, they ask really awkward questions. They're difficult conversations. So I want people to work together and communicate as best they can and try and make this work. I'm delighted that the framework encompasses all of healthcare, because I think that's important, that there's there's nobody in healthcare now that doesn't know their obligations within open disclosure. It's widespread now. when I heard the words first, I thought, what's open disclosure? Duty of candour, I didn't understand it. But really, peel it back. What is it? It's honesty. It's your honesty, and it's your honesty and relating to people. And people are reasonably forgiving. If you approach them and you have that conversation, you'd be surprised. I think that, you know, it's a surprising space to be within. So that's sorry, that was very long-winded.
No, thank you. Thank you very much, Bernie, and thank you in particular for that balance that you brought to your response. And building on that, I might ask you, Kathy, based on your own experience and what you've heard from Angela, somebody involved in training and promoting open disclosure, and from Bernie, who has her lived experience. What are the important things to build that culture of open disclosure in a hospital or in a service, and the people who are involved in open disclosure? What's their concern? What are they worried about?
All right, so there's two questions in that. So the first one, in our experience, to build the culture, you need to find a champion, and I can't stress that, how important that is. And it needs to be somebody with a genuine interest. And with all due respect, it does not need to be a clipboard character. It has got to be someone on the front line who is doing this day in, day out, and actually lives this. And somebody who's close enough to the patient to be genuinely concerned for the patient and feel that they're their advocate. You need to have that person. This is not an office job. So that's what we did in our place. When Angela approached Moya Wilson, who is our quality manager, who's a superb manager, she's superb, she's a very practical lady. And they approached me and Anya Mitchell. So they found people who were interested in education and interested in open disclosure. And then I think you need to find what works locally. For us, I've spent the last 12 years educating doctors, nurses. That's one of my primary interests in the hospital. So I know, for better and worse, what works and what, more importantly, I know what doesn't work. We've had many of those. So what works for us is we do it team by team. We do nurses, we do docs, we do HCAs, we do medical students. Everybody gets in together in that team. We then find a time that suits that team, where they're not being pulled in 50 other directions. They're not post-call, they're not in the middle of a clinic. They can actually do it. We keep it short, we keep it sharp. We do not have a PowerPoint slide in sight. I think PowerPoints are the worst thing that ever happened to education. And nothing will put me to sleep quite as fast. So what we do is role play. And we have a couple of scenarios ourselves, and we ask each team to bring a scenario and we discuss it. And different scenarios evolve during the course of the discussion. And they're real life practical scenarios. And I might be acting the side of the patient, I might be acting the side of the HCA, it could be any. But it gives you a perspective of all the different sides. It's really, really practical. And I think in our experience, it is the only thing that works. And it needs to be led by whoever's the clinical lead on that team. So I attended, and my team will attend because I attended. My junior docs will look at what I regard as important and will view that as what they would regard as important, if that makes any sense. They will mirror that to an extent. And I think it's really useful to do it as a team, because we each have a different role in the team. I would say one of the things that we have learned is lunch is probably the biggest attractive element that we can actually put in there. And it doesn't have to be fancy. A few sandwiches and you will have the place, you will pack it to the rafters. It is just the simplest little thing, and it'll get everybody on. And the other thing we do is it's mandatory for every team to do it. Now, that said, you're always going to get people who won't engage. And I can tell, I'm sure you can tell in your institution, who are the people that we are wasting our time with. And they're probably the people who need it more than anyone else. But all we can do is our best, and we will educate those who are willing to be educated, and we will let it perfuse through on that basis. And that does work. You'll institute change one person at a time, and that's really how you do. That's how any of us do it. The thing that we're frightened. There's a lot of things we're frightened of. If that's your second question, one is obviously being sued. I suppose that is an issue, and it's not so much the legal side of it as the reputational damage. I've been graduating now for about 27 years, and it's taken me a long time to get to this stage. And I don't really want to be on the front page of the Daily Mail next week for something that's out of my control. And largely, this is out of my control. And how they perceive it is out of my control. And that, I have a mum who reads these things. I have, it's a very personal thing. And I really don't. And we're all frightened of that. And what's more is none of us go to work any day to do harm to anybody. And we are so vulnerable. I did my entire ward round yesterday. I saw 22 patients in the corridor in the emergency department. And there's people passing me by, there's trolleys coming in, there's stuff going on over my head, there's drunk people coming up to me. I've no clinical notes on anyone because nobody's gone down and got any clinical notes. You know, the computer's down, the CT scanner's down. I am being set up for a disaster. You know, how I come out of the day and not have a disaster is nothing short of miraculous. So we feel extraordinarily vulnerable. And if it hits the fan, I can tell you, and I'm sure every clinician will tell you here, people will run for cover. And you are the last man standing, and they absolutely run for cover. And most of it is out of my control, and yet I am the one carrying the can. And that I find very frightening, because it's so far out of my control. And the other thing is that, we can see this coming at a million miles. I can see these happening up front of my eyes. I can see it coming at them, and there's nothing I can do about it. And that's a horrible state to be in. I suppose they're the main things. I suppose the institutional support, I suppose, is the other thing. It's that running for cover. When it hits the fan, I can tell you that none of the management are going to stand anywhere near me. They will not. And I am left. It's my face is on the front of that Daily Mail, and that I find really scary.
Okay, well that's a very honest frontline account of what it's like to practice in this. And I get to ask Morris rather than answer your question or address those fears. And Morris, what does the open disclosure framework do to create a culture of change that promotes openness and transparency in the current environment?
Yeah, that's a very good question. There's a lot of elements in there. The open disclosure framework itself isn't a prescriptive document. It doesn't say if X happens, then you do Y, Z, or whatever. What it does is it sets, I suppose, the overall kind of principles. One of those principles is support for the staff. That's the key thing. It's not just coming from a patient's perspective. Absolutely, patients are entitled to open disclosure, etc. But somebody mentioned relationships earlier. There's two sides to that relationship. There's the person who is being disclosed to and should be disclosed to. There's the person who's doing the disclosing. That person has to be supported. Supports, one of the key things for health service providers are supports have to be put in place for professionals, all staff in the health service provider to make an open disclosure, to feel comfortable making an open disclosure, to not face, as was said, everybody else running for cover and all of a sudden the clinician or whoever it is there on their own. That's not something that changes overnight. That is something that needs to be written into individual policies, and the HSE's policy has it. Other organisations' policies will need to have it as well, and it needs to improve. I suppose from listening to Secretary General this morning and the CEO of the HSE, the word that they used many times over was embedded. This culture needs to be embedded. These ideas need to be embedded in the policies. And no, I don't expect when we get the first reports in 2025 that all boxes will be ticked, job done, the National Open Disclosure Office can stand down. It's a journey, but the first step on that journey is getting the message out there that supports need to be in place, I think. Angela might have more to say on that in terms of from the HSE's perspective, or Lorraine.
Thanks very much, Morris. So, just coming up on Slido and touching on what Kathy has had to say, and Lorraine, I might address this to you. We've done quite a lot of work on just culture, and how we get that balance right, and encourage people to disclose, and feel safe in the environment in doing so, and that others won't be running for the hills. So would you like to comment on how how we can encourage people to attend for training in open disclosure and participate and undertake open disclosure when it's necessary within a just culture.
Yeah, I suppose you've touched on a couple of things, and I think all of this feeds into our bigger theme in terms of the safety culture generally. So open disclosure is a big element of that. Just culture is a big element of that. And all of that together are kind of areas that we need to recognise and implement and address. Angela and the team have a fantastic training programme, and certainly we keep seeing our figures and engagement, and the fact that within the HSE it is mandatory to do your open disclosure training. They are constantly on the up, so we know that there's engagement with regards to that. The face-to-face is a challenge, and we know how busy our clinicians are, and having just listened to Kathy there, how do we capture that audience? And they're really the key part in terms of kind of delivering those open disclosure conversations and meetings and that. So it's about looking at how we can reach that audience, and looking at novel ways. And we're engaging with Dara Byrne, for example, the national simulation lead, and Eva Doherty and Angela did a fantastic piece of work around simulation, something that we know clinicians buy into. And how can we bring the incident management open disclosure piece to get in on the agenda of that, because we know that clinicians like to learn in that space. So it's being a little bit novel and thinking about outside of the box. And I suppose as many people say, we know now, I think, across the healthcare system that we need to do open disclosure, that we need to be open and transparent with those who are impacted by those incidents. But it isn't easy. And learning the skills and how to do it, it won't suit everybody, but I think, Kathy, you touched on it a little bit there as well in terms of, the potential for compounded harm to a person. So we know we need to tell them about the incident, but actually how do we do that? How do we involve them in the review process and that, so that they don't experience compounded harm by the process that follows on from an incident, and actually bringing that into the training space. And a bit about the piece around running from cover. It's often said in incident management, we don't go to work intending that somebody is harmed, but we know that if there is an incident and that there is harm, that there is a risk of compounded harm for that person. So pretty much like when we deliver clinical care and try and prevent, ensure the best outcomes for patients, that afterwards we also come together and prevent that compounded harm and support one another. If incidents cross over specialties or the community in acute setting, that we really come together and prevent that compounded harm.
Thank you. Yes, I often use that concept of compounded harm, and I quote the 4th Earl of Chesterfield, I think 400 years ago, said, an injury is forgotten far sooner than the insult that ensues. And I think that's true from both patients' and staff's perspective as they involve themselves in open disclosure. Caroline, would you care to comment on interdisciplinary working as it pertains to, or training as it pertains to open disclosure?
Yeah, I think, nowadays healthcare has changed so much. I come from a profession, we're regulated as a profession of nursing, so there's 85,000 nurses on our register, so we traditionally would have worked in silos. Nurses would have looked to nurses, and doctors would have looked to doctors, and physios, and the whole way across. It has completely changed now. So now all of healthcare is interdisciplinary. So as it was alluded to earlier on this morning, the patient or the person is not just looking for the one voice to fix them. They actually need a whole team of people to fix them. So I think from an open disclosure point of view, if we learn together and train together, we're much more confident in dealing with each other. So from us, we would say that interdisciplinary education is incredibly important. So as a model of regulation, we would say we want to upstream regulation. So that's where you look at things before they happen, before the incident and the harm happens, that you give the education and you spend much more time and energy preventing the harm beforehand. So the best place to start, I think, is in first year, in the first training school of whatever program you're doing, and you need to start it from day one. And just letting our professionals know you're going out to work as a team, and you all have to work together, and that silos shouldn't be there. That we know they still are, but they shouldn't be there anymore, and that we need to If we learn together, then we'll have that confidence. And to me, it's that confidence piece. We spoke about it earlier, about that anxiety that staff feel around open disclosure. And as you said, Bernie, it's anxiety about telling the truth. So we need to teach our junior staff. So it's the student nurses, the interns, all the junior members of staff. It's okay to be honest. We need to give them that space and that latitude to be honest. And that's where I know we were talking about the simulation piece. I love the idea, the fact that simulation is finally coming to Ireland in a meaningful way, because that's one of the best tools where people can learn to make mistakes in a safe place. So I think that's going to be a game changer for education in Ireland for all of our healthcare professionals, that they can go into a lab and work with the nurse beside the doctor, beside the physio, beside the care assistant, and they can make mistakes. And then they get to debrief about it and learn in a safe place. This is what I'll do next time I come across that. Instead of trying everything out first time on a real life patient, we'll actually get to do some role play and some scenarios and problem-based learning that way.
You're bang on. Simulation has been embedded in training and education for quite some time, but it is the next big thing in patient safety, and the potential for patient safety hasn't been realised. So the types of scenarios that Kathy described, the training sessions that Angela described, and as you've eloquently put it yourself, is the way forward. So Georgina, from a patient advocacy perspective, what is the contribution of an advocate to open disclosure?
I suppose from our perspective, there's several aspects to our role in open disclosure, and they're reflected within, I suppose, the principles of the open disclosure, and especially within the framework. And it is about supporting that open, honest, compassionate and timely communication for people, strengthening the patient's entitlements in and around open disclosure, and driving that embedding of that change of culture for open disclosure and that just culture. And then also, I suppose, for us, it's using our data and the stories that we collect, for that reflective practice and those learning opportunities, training opportunities, and looking at that policy adherence that we have. We are an independent, free and confidential advocacy service. We're totally independent of the HSE and all other services that are there. And what we do is support patients and their families through complaints and also patient safety incidents, which would encompass the open disclosure framework. Our advocates are trained and they're trauma informed, which can be vital, especially around the patient safety incident, because that can be a very daunting time. We offer that safe space for people as well to kind of talk about their story, see what they want done. We have that human rights, person-centred based approach, where what we're doing is giving the person a voice to raise those concerns or what their needs are, or maybe what their expectations and preferences are. And also, I suppose, that they're kept at the centre of that process. From a practical point of view, as advocates and as a service, we can kind of, I suppose, develop that health literacy and get that understanding around it, where if something does happen, what is open disclosure? What is the impact? What is going to happen with the process? What they can expect to happen? They mightn't know about a designated person and maybe the communication opportunities that are there, what the incident management framework would involve. So we would explain all of that and give them advice, give them, what their options are, how they approach the hospital or the nursing home in that aspect, how they relate to their designated person and that. And then I suppose we can support people to prep for meetings if they have open disclosure meetings, even, I suppose, making sure that the emotional and the physical environment match the occasion. And we can attend meetings with them and that. And it really is about elevating their voice and giving them the opportunity to share their experience that can inform, those improvements and really see that learning from it. The other aspect to it is, as well, with the experiences that we're bringing forward, it is that embedding that culture, that changing that culture so that open disclosure does become the norm, that the policies that are already in place, we're in the acute hospitals, so we work quite a bit with the HSE open disclosure policy, and the framework is building on that. But it is having that consistency of care, that it shouldn't matter where you live, where you're based, what your financial circumstances are in relation to the service that you should get, and especially like if you have been impacted by that. So what we can bring, speaking of, I suppose, the positive as well as the negative, we can, you know, in elevating that voice and bringing that experience forward, we can, you know, drive that change, I suppose. We bring that information we have, engaging in the partnerships we're building with relevant stakeholders like the open disclosure team themselves, the incident team, you know, the regulators, the Department of Health. It's bringing all of that, and I suppose reinforcing those policies and practices. You know, we're working on the ground with people, and we can share those positive experiences of when it does work well, and the impact that it can have on a patient when it does work well, when they have that, as Bernie was saying earlier, that open, honest, that compassionate and empathetic kind of communication, that learning to come from it. You know, most people just want that acknowledgement, that apology, and that they don't want it to happen to somebody else. And I think as well it's important where it is a learning process for hospitals, and that the human element isn't forgotten within that, and that the patient's voice is really, really important within that, and it's all about enhancing the patient experience. So that's like as part when somebody is impacted, it's not just, I think the priority for people sometimes is their immediate care and the additional supports being put in place, and advocacy plays a role in that, and being that additional support that we can support people through what is a traumatic event, and then also, I suppose, enhance the processes that are there, making sure that they're applied and implemented, and then the learning going forward from that.
Indeed. Thank you very much, Georgina. You mentioned a human rights approach, and Sean, human rights were mentioned in the HICWA context earlier this morning as well. So I think we all have quite a clear idea of HICWA's role and function, but could you elaborate on the HICWA role in regard to open disclosure?
Sure. So I think the key word that's been used throughout this presentation is culture, and whenever you're trying to attempt culture change, is an extremely difficult thing to do. It requires everyone to play their role and every lever to be pulled over time. I think if I reflect on my own patient safety journey over the last 20 years, I think there has been movement from where things were. There is a road to travel. From our perspective within HICWA, the focus on open disclosure has always been there. If you look at a lot of the serious service failures that we've been asked to investigate in the past, one of the key failures has been that communication loss between those that have been harmed and the system. And I think, that this framework and what's expected through the Patient Safety Act more generally will act as an additional lever and a barrier or a baseline really in terms of performance. From our perspective, under the Patient Safety Act, we'll have an expanded role. That role will see us receive notifiable incidents where we'd expect open disclosure to happen as per the legislation. And I think importantly, and it hasn't really been captured beyond what the Minister has said, this framework applies both across the public and private system, acute and community, and I think that's absolutely critical, that there can be no ambiguity across all of healthcare in relation to what's expected. From our perspective, we will be monitoring services in relation to the application of the framework. It's important in driving culture that the leadership is there and that the structures are there to support people to perform. And reflecting on what Kathy said there earlier, it shouldn't fall on individuals when things go wrong. It's the responsibility of the organisation to provide the supports, not just for those that have been harmed, but equally anyone else who's involved in the incident. And I think that's absolutely critical. And we'll be looking to drive that, and certainly it'll be something that we'll be looking to shine a public light on. I think finally, as we all work to implement this framework going forward, there's a requirement for shared learning. And I think through our work, we publish all of our reports. We'll hope to actually enable learning across the system and work as an active participant in this journey as we all seek to try and drive an improvement in culture going forward.
Thank you, Sean. I think that we're right on time, actually. So maybe you'd all give a big round of applause.